Hi, this is Dr. Andrew Gumbs. This is, I think, my God, I'm losing track. Maybe episode 7, maybe 8. I'll have to go back and look of artificial intelligence and cybersurgery. I'm the editor-in-chief of the journal Artificial Intelligence Surgery, which is the first journal dedicated exclusively to artificial intelligence and surgery. And I'm here with my co-host, who's going to introduce our guest for today's episode.
Hi, everyone. Yeah, I think this is our 8th episode, and it's getting exciting. We've got people from, the European and American theaters now. I'm Dr. Vincent Grasso. I'm the social media and strategy director for our journal, Artificial Intelligence Surgery. You can find this at aisjournal.net. And very happy to have as our next guest. I think Dr. Antinori is the first American we have on, first American surgeon. Is that
maybe?
So we have Dr. Charles Antinori on our podcast, and welcome, Dr. Antinori. Maybe we call you Charles or Charlie. What
Charlie.
do you prefer, bro?
Charlie.
Charlie. Okay, good. And I have a long history in some ways with Charlie. His sister is married to my cousin, a very dear cousin, who's a very, very interesting artist in New Jersey. And Charlie and my cousin Doug were friends, in I guess high school, right, Charlie? You guys were
right.
You guys lived
Maybe even grammar school.
Yeah, I mean, they go back quite a way. Charlie was a big inspiration for me becoming a doctor and a surgeon. He was in the neighborhood, serious academic guy, and my uncle was a surgeon, just like Andrew's father's a surgeon, Charlie, and that's what motivated him. So we've got some of those linkages together. But
Vincent mentioned Doug. Is it the Doug that I know? No, a different Doug.
It's another Doug,
Okay.
another Doug the Pice. So he actually is going to do some artwork for us, Andrew, for our podcast.
Very nice.
So it's great. So let me introduce Charlie. Charlie has you'll see on his LinkedIn profile that we'll post later. He's got a pretty compelling academic background: Regis High School, Cornell, Dartmouth, Harvard Medical School, Columbia PNS Surgery, and then he worked with Dr. DeBakey in his CTS fellowship. So he's got a very, like you do, Andrew, pretty interesting background.
Yeah.
And what I'm really excited about is, he has been involved in very cutting edge surgical technology from when he was in his fellowship. And we all know what Dr. DeBakey, pioneered. And he's seen the transition of analog surgery into a more digital environment, naturally working with robots here and there, and now seeing the potential of more technology in the OR. And I think it would be great to hear his perspective and some stories about his training and what he sees moving forward. So Charlie, thank you for being our guest, and we'll turn it over to you.
Okay. Yeah, I don't know. I guess you wanted me on because been around for so long. It'll be 50 years. It's basically 49 years now since I started residency. So, like I said, I started out before there were CAT scans.
Wow.
we had people in the emergency room, we did all the head trauma and everything. We got skull films, which were useless, I think there was an article in the drawer of the emergency room that was 10,000 skull films that didn't disclose one unsuspected skull fracture. But that's what we had to get for the head trauma, and the thing that used to tick me off was that the skull films cost like $65 a piece at that time. This is like 1973, 74.
That's real money. Yeah.
And I was making like $50 a day for working 24 hours.
Yeah.
24 hours on, really more like 28 on, 20 off, in the emergency room. But, and then, as they say, bit by bit, I don't know if you remember this, the CAT scans at first were only of the head. Then after a while, they took over the whole body, and, and they've gotten better, so much better and better. But
it's hard to even imagine that. I didn't know any of that history.
Yeah, it really, and then the funny thing too is like at our weekly M&M conferences, for years, into the 90s, like the resident would be presenting a case and something went wrong, and they'd say, and we took the patient a CAT scan, and somebody would always chime in like, why is it you going to take everybody to CAT scan? We felt like we were overutilizing. The answer is not a bad idea. I kid the emergency room doctors and tell them that we could replace them by a robot that says, show me where it hurts and I will scan it, you know. Pretty much now everybody gets scanned, you know, when they roll into the emergency room. But and it's not a bad thing. I mean, it really helps out tremendously. Of course, it has driven the cost of healthcare up tremendously. But
but so many misdiagnoses. I mean, I can't.
Right.
I mean, I don't even want to imagine life before then. But
even simple thing.
It reminds me of the old adage where people used to say, "What first they ridicule you, then they argue with you, and then they say how they knew it all along and they agree with you."
Right.
You just keep reliving these same idiots resisting innovation.
Yeah.
You know?
Even like really simple little things like ventral hernias. You know, before you had the CAT scans of the body, and a lot of times, you know, the really heavy people come in and they're telling you they got this little lump, and you could, you know, barely feel it, and sometimes you get talked into operating on it, you know, and then you get down there and who knows what you'd find. Maybe it was a hernia, maybe not. Maybe there's another hernia right next to it, you know. And now, pretty much before I fix any of that, I make sure to get a CAT scan, so I have another way of looking at it besides just physical exam, you know.
Yeah, absolutely. No, absolutely.
You know, interesting, Charlie. We had met a couple of weeks ago, and Andrew, I guess a compliment to your domain. We were speaking about surgical training and residency, and kind of, you know, the lack of a lot of open procedures for surgical residents hepatobiliary wise, right? So you did a fellowship in hepatobiliary, that's your specialty. And Charlie, I think you did make a comment that, you know, the residents today, like even I think in my training, we didn't do a lot of hepatobiliary work until you did a fellowship. Right. And there's less open cases, and you know, that's an interesting problem for training surgical residents today, right?
Really, yes, yeah, in all sorts of different ways. I'm sure Andrew knows what but like I'm a associate program director in program in Spear in South Jersey, Vineland, and I'd say half of our residents go on after they finish the 5 years with us, go on and do like a minimally invasive fellowship. They almost all go up on and do some sort of fellowship. You know, some go into breast, some go into vascular, different things. But I'd say about half of them, and with that, they end up doing bariatric and minimally invasive. They get more minimum. But the fact is, they're getting so much minimally invasive training in the 5-year residency now, because we're doing hernias and a lot of things. You know, we have a robot. You know, they're getting pretty good at minimally invasive. And my feeling is, they ought to be doing maximally invasive fellowships, because they're not getting into. They're nervous when they get in the abdomen. I can tell, you know, when I have to do an open case, then I'm way more comfortable on an open case than I am laparoscopically. I haven't started doing a robot, but laparoscopic, I do a lot of things laparoscopically, but I'm still, if it was up to me, I just open the people.
No, but it's a
laparoscopic's a lot better.
It's a real big problem. I mean, seeing a young surgeon try to do an open cholecystectomy, it's hard to watch. You know?
Right.
It's painful, and that's why one of the reasons when I finished residency, I did an open pancreatic surgery fellowship.
Where'd you do that?
I did a laparoscopic surgery fellowship, and then I did a minimally invasive liver and pancreatic fellowship, because I knew that, you know, I didn't have all the elements. There's no fellowship that exists that has all the elements. You need to do multiple to be trained. And I really feel passionately that you need to be formally trained in open, formally trained in, you know, laparoscopic, and formally trained in robot. Really, is that's the future. Future surgeons need all three things in their wheelhouse, which is an expression that I take from Vincent.
Yeah, it's it really is. That's what we're seeing. Like I say, when you get into the abdomen, like I make them cut and tie. Just maybe a week ago, I had to do a small bowel resection, incarcerated a ventral hernia or something, and he had some dead gut. You know, they all want to use the ligature, you know, like to go across the bowel. You know, the ligature is $500. You know, just to open it. We don't get paid $500 for a lot of operations now.
Right.
And
then
just wheel across the mesentery for like what?
The wheel of like 3/0 vicryl is like what, $30?
Maybe, if that sounds like a high estimate, you know.
Right.
And it doesn't even take that much longer, you know, to go across the mesentery with the, you know, that's I make them do, but you know, it's really funny. And then the robot, I'm still trying to figure out where the robot is going to, you know, fit in. Like I'm mostly doing thoracic now, still do general, because it's very hard. I found my entire career it's very hard to stay busy. It's doing just chest thoracic. When cardiac was rolling, we were doing great doing cardiac. But there's really just the volume of chest thoracic is just not that great in a lot of places. You need a huge catchment area. So I ended up doing about 50 general and about 50% thoracic. In thoracic and the robot, I went down to Serfolio, who's I don't know if you heard the name. He's like the maven of the robot in the chest. He was at Alabama originally, which is a great thoracic program. Actually, it was considered the best in the country when I applied. And Birmingham.
I think pediatric laparoscopy is fantastic in Alabama too. I mean,
yeah, it's you would never think this, but right in Birmingham, you don't think about Alabama as one of the great intellectual centers of the country, but
it is.
But it is in this one.
Well, like Iowa, right, with eye surgery on the top of the country, and there's all these jewels all over America. You just have to know where to go.
It's usually just some really good guy starts the program and then just recruits good people, and then they just keep recruiting good people,
Right.
But anyway, he actually went to NYU. I heard he's at NYU now, but he I watched him do the surgery for a morning, and he was really kind of nervous. I mean, this guy had published at that point about 1,200 cases or something, and lobectomies, and the problem, is the lack of proprioception.
Haptics of touch, of course.
Yeah, and the fact that you're not even scrubbed, you're sitting on a console.
Oh, I love you. Yes, music to my ears. Exactly. Yeah.
Specifically on thoracic surgery, I'll tell you, when I do it either, thoracoscopically or even open, I'd say, I don't know, a third or half the cases you get into some kind of a nasty bleeder. You can control it, but it's, you could lose. But if I had to de-dock, scrub, and open the chest, I can't see how you can do that in less than 20, 25 minutes. And even like a relatively minor bleed from the, pulmonary artery or pulmonary vein or something like that, you could lose an awful lot of blood in that period of time.
Vincent and I and some editors of our journal just published a white paper on autonomous actions and kind of the importance of different definitions of robots, like whether
that's when I looked at, right?
Yeah.
Okay. I didn't really read it great.
No, I'm actually gonna switch it on you in a second, so don't worry. But the issue we talked about in those guidelines is whether handheld robotics are safer or more intelligent or enable us to advance further in surgeries that have a lot of bleeding, like HPV surgery, and it's nice that you mentioned thoracic surgery because that's another huge problem. But in the fact that we only have actually about 12 minutes, I actually want to talk about some new guidelines. The publishers asked me to start developing a concept for a new guideline, and I've been talking with some other editors, and one of the things that we like about artificial intelligence, aside from the robotic and the autonomous actions, is the fact that artificial intelligence can eliminate subjectivity. And what I mean by that is a lot of times, it took me a long time in residency to realize surgical indications are not just what you read in the chapters, right, in the textbooks. It took me a long time to realize that some surgeons book cases with questionable indications because they're a little light that week, and all of a sudden it becomes an indication for surgery. Like, oh, I didn't know metastatic pancreatic cancer was an indication for surgery. Mm-hmm. Well, apparently it is. And in the sense that in tumor boards, in places with powerful chairmans or what have you, the indications get lost. Or there's a big problem with mobbing. If there's a surgeon that somebody doesn't like, a lot of people will question their indications, even if it's BS. Right. So I wonder if we should talk about the power of artificial intelligence able to eliminate subjectivity in medicine, because there's a lot of subjectivity. And I just wanted to know what you thought about kind of what I'm saying, if the surgical world is ready for something like that, if I'm out of line thinking that we should talk about this issue.
Yeah, no, I think it sounds definitely, I know what you're talking about. The funny thing too, like when we talk about, I'm on the performance improvement committee, and I've been on one pretty much all the time, that they've been since they invented them, 20 or 30 years ago. Yeah. And we talk about it for some time, when you talk honestly, you're at those meetings, and half the time, either everybody in the meeting is your partner or your competitor. And it's very hard to be objective about either your partner or your competitor. If it's your
Absolutely.
partner, it's fine. If it's your
Yeah.
competitor, you screwed
Yeah,
up.
you're an assassin. Like it's like right, black and white. Yeah.
Yeah. You just reminded me of something else. It's funny that since Vincent, started talking to me about this, which is just a couple weeks ago at the 50th wedding anniversary, I've been sort of paying attention. And just a couple days ago, we get an email from our research director congratulating one of the residents on a paper that got accepted for the surgical forum. And I talked to the resident. I said, I go, congratulations. He goes, wait, what? He goes, I said, you got a paper at the surgical forum. He goes, oh yeah, that's that AI paper. He goes, I really didn't do very much. He goes, we just took some information that Dr. Slotman, who's a research director, pulled a bunch of articles from like the 80s about one of these anti-inflammatory drugs that had been used back then, and thinking about using it for COVID, and just had some type of AI program that goes through and does a randomized,
An analysis.
The multivariate analysis where they control like one variable, and it can do thousands of analyses, very, very quickly. That would take, doctor, us work by hand, months.
Absolutely.
And they got an article that published that's going to be in a surgical forum out of this, just reviewing data, from a long time ago and seeing if it may have some application in use for COVID.
I mean, I just think about how many times there's new guidelines and how many times we're discussing, the new guidelines. And then we realize we've been discussing guidelines from 3 years ago. We haven't been updated. It's so hard to keep up with everything that let's face it, it doesn't happen at the rate that it should. And AI is the way that we're going to, enable people to get the best recommendations, the latest, and easily. Otherwise, it's overwhelming for us, and it's a real shame for patients. And when we have the technology and the information sitting right there.
Yeah, like I say, I think this is, it's like a whole new era, in a lot of things. The electric cars, autonomous driving cars,
So Vincent, what do you think we can call those guidelines? What do you? I'm thinking the ethic. It's not even the ethics of AI, but the power of AI to eliminate sensitivity.
Well, there's a big movement now for transparency in performing analyses using AI, because Charlie, you think about the power. So the people that know how to use tools in AI have a big advantage over others, right? It's kind of like alien technology. We can do things with data that you can't otherwise. How you construct those algorithms is a very interesting, now political discussion, right? There's algorithms being used to do all sorts of things. So there's a big movement for transparency in AI. I believe, Andrew, you're on to something very compelling, because you want transparency in how surgical indications are being promoted, generated, et cetera. Patients want to know why they're being operated on. They never want to be operated on because somebody's not busy. And that's kind of not a great idea. So we should pursue this. I think this is something this is an ethical, medical ethical,
But it's like reverse, because people talk about the ethics of using AI, and it's like, no. AI is not the problem. We are the problem, and
we're the problem.
Eliminate.
Yeah, we use it. We create our own bias. And I'm really interested, Charlie. I didn't know that you were involved on the surgical training side. Let me propose the following, just for a follow-up conversation. Number one, we heard that Charlie's residents are going on to doing fellowships. Andrew, you came out of, you did general surgery at Yale, then you went to Europe and did hepatobiliary stuff in Italy and in France, everywhere else. Is there an opportunity maybe for us to help, or at least have a discussion with, suppose there was a hepatobiliary interest in one of his chief residents that, can we help place them? Are there opportunities for US residents to come to Europe for some more training? I mean, is that something?
Well, absolutely. I mean, the problem is not coming here. The problem is getting the time from the residency program. It's probably easier during fellowship. They're very strict. The ACGME is very strict with how many weeks off and hours and all this thing. So I'm not sure it would be very easy for someone to come here. The only problem would be the language, of course, but if they're with me, that wouldn't be a problem either.
The other thing is, just in closing for us, Charlie, is Andrew and I are starting to doing kind of symposia, right? We're giving like a 1 hour briefing, a formal briefing on AI. Maybe we could do something for your residents in one of their morning meetings or something, and give an intro to AI as on the surgical side is what the journal's about. That could be a nice educational primer for maybe the residents, if that's of interest to you.
That definitely, yeah, that would be easy to do. It's actually Thursday afternoon, and again, as Andrew said, the GME has rigorous standards. They get 4 hours of uninterrupted time, which again is an old timer. That's
wow,
mind-boggling.
You're mind-boggling.
4 hours a year.
But they're really good. So it would be easy to fit something like that in.
Okay.
Definitely.
Be nice, Andrew. We could give a briefing on that.
Great. Well, believe it or not, I'm most surprised at how quickly these go.
Wow.
But that's about the time where we have now. We like to keep them short and sweet. So it's very nice meeting you, and I'm definitely looking forward to having you on again in the future. I thank you so much for your time. It's so great to have someone with your background and your history. DeBakey, I don't know if I think I've mentioned this already in the podcast, but I'm always so impressed by it because one of my partners, my chairman is Lebanese. DeBakey's Lebanese, right?
Yeah, he was. We were born in Lake Charles, Louisiana, but his family's Lebanese. They came over there to avoid some kind of religious persecution that was going on at the time. And they were,
Some things never change, unfortunately.
Right.
And he moved to Louisiana, huh? Wow.
Yeah, and they moved there specifically because they spoke French. There was an area of Louisiana that basically spoke French.
That's
I just looked a lot of this up last night, actually, kind of to prepare for this.
That's amazing. Well, he was a Maronite Catholic, I think. So
right, Maronite Catholic, exactly.
They had issues, but your friend is a big hepatobiliary surgeon too. The Lebanese guy, your Lebanese doctor.
He's actually shifted more. He's actually very big in obesity surgery, laparoscopic surgery.
Bariatric.
Professor
again. There's a lot more obesity surgery. It's kind of like I say about thoracic. There's a lot of obesity surgery. There's not, all that much hepatobiliary. You wait around for people to screw up gallbladders,
Well, what's interesting about that is the amount of pancreatic cancer is increasing steadily, and it's going to overcome in incidence many of the other cancers. I think it's going to be the third or fourth most common cause of cancer deaths just in the next 4 or 5 years. So. Unfortunately, I would love to be out of a job, but in Europe with all the alcohol, all the cigarette smokers, pancreatic cancer isn't going anywhere, unfortunately.
Right. Well, you had to wind this up. One of the papers, I trained at Columbia. That's where Alan O. Whipple was the first chief of surgery when they opened the hospital.
I actually did my fellowship, and I was a young attending there. I did the first laparoscopic Whipple at Columbia. So I was
no kidding. It
was a little feather in my cap. That was a big honor for me. Yeah.
We'll talk about Whipples maybe the next time.
Yeah, next time we'll talk about stuff.
All right, guys. Well, great talking to you. Thank you for giving us time on your Sunday, and we'll be in touch. Okay.
Very interesting.
Take care. Thanks, Charles.
Bye-bye.
We'll see you soon. Take care, everyone.